probably haven't done it before.
So it is my pleasure to introduce our speaker for today, Dr. Antonio Morgan-Lopez, who, amongst other things, is a very close collaborator of our group as well as a friend. And so I'm really glad that he could come here to the Center of Alcohol Studies, our Emerging Addiction Science Seminar. And before I go into like the formal introduction, I wanted to just say that when I was thinking about introducing you, that the one thing I wanted to say was that you know, there have been few things in my life where I felt like I won the lottery, and meeting Antonio and working with him is one of those things that I would say is high on the list. And the reason is that in my world of clinical trials, it is often, you know, one of the key things is how do we analyze and make sense of the data of what is very confusing, potentially human, you know, participants in our studies that have lots of, to the best of our abilities, we try to plan for everything, but you know, humanity intercedes, and our data sets are often very complicated and hard to sort of bring truth to. And his kind of innovative and creative quantitative ability, kind of paired with understanding the human condition, really has helped to illuminate not only our work, but also the work out in the field, and that's what we're going to be hearing about some today. So, you know, some examples include when we first met, he was developing these analytic methods for modeling membership turnover in rolling group therapy. So what does that mean? Well, in most addiction treatment settings, patients are treated for behavioral interventions, their psychotherapy, in contexts where you have rolling groups. So patients come and go, membership changes over the course of multiple, you know, sessions, and that's the real world. But research-wise, when we think about how do we actually analyze those data and what are those assumptions that we bring to it, and do the data analytic methods help us to understand membership turnover, the answer is not so much. And so he and colleagues have developed, but really he developed these incredible models and actually used the New York Knicks as one, membership turnover from the 1960s to the 1970s to simulate the condition of membership turnover as one example.
Serious research.
So I encourage you to look up that. That was published in journal JSAT, I think. But anyway, he comes to us now from Research Triangle Institute, RTI International, and is a fellow, which is an honor, in quantitative psychology in the substance use prevention and evaluation research program, you know, at RTI, and work centering around the development and application of advanced quantitative methods in the context of randomized and also non-randomized behavioral health interventions. He's served on as PI on 4 NIDA and NIAAA grants and has been funded since 2006. And many of them center around advancing the quantitative methods on PTSD and substance use treatment. He did his Ph.D., by the way, at Arizona State University, and has worked with colleagues like Lori Chasson and also Dave McKinnon. He's made significant career contributions in applying quantitative methods across multiple fields in the social sciences, economics, and biostatistics to applied research and evaluation in broad areas of mental health and clinical services research, as well as a lot of school safety and evaluation projects in his record, and has been highly productive in the dissemination of his finding and has published many, many articles, high impact in high impact journals. Also has distinguished himself, I just want to mention, as a very generous mentor, and particularly as an African American and Latino scientist, has, you know, in our some of our training programs has really shared his personal journey along his professional trajectory and really been open to talking about barriers and how he overcame them, and so is a really inspirational role model for students and also, you know, junior faculty. So just very happy to have you here and welcome you, and we're excited to hear about your topic. Thank you.
You know, Denise was going to attempt to try to make me cry a bit begin this talk. But certainly it's always wonderful to spend time with Denise and Alicia and Sky and members of her lab, but in particularly an equal pleasure to spend time here at the Center for Alcohol Studies, where I've sort of followed along you know, the path of different investigators here, past and present, and you'll actually see some of this, so we'll see a little bit of this in talk, where some of the work that you know we've begun to do in terms of meta-analysis of individual patient outcomes and integrated data analysis bears a little bit of earmarkings of both some of that work with Laura Chaston, Matthew and others may work with her, but also some of the work that Young Moon initiated while she was here. So there's actually, again, a little bit of CAS influence on some of what I'll talk about today. Now, the title that I've got for the talk is When Patients and Clinicians Disagree About PTSD Symptoms. And I mean, if this were a symposium, a series of talks at a conference or a meeting, I could easily talk about that in 15 minutes. But since I've got an hour, what I'm actually going to do is give a lot of the context for how some of those ideas were generated, sort of in an unintended fashion. And I'll actually give a little bit of a larger history of a current grant that Denise and I are MPIs on, funded by NAAA, to look at a meta-analysis of 50 treatment studies for cohort PTSD and alcohol and other drug use disorders. Now, I can actually re-subtitle this talk as ideas that you come up with when on moderate dose Dilaudid. And there is a little bit of a backstory with that in terms of when some of the ideas came about for moving into this framework of common persons IRT calibration that may correlate with the time that I was recovering from knee surgery on Dilaudid. I don't know if it's causal, but maybe it is, maybe it isn't. So, give a bit of an overview before I get into the meat of the talk. So, I'm going to talk some about Project Harmony. It's the study that Denise and I are doing along with Alicia, Sky, maybe a cast of dozens. Give some of the origins and background on the study in terms of what the state of the literature was at the time that we submitted and got the grant. I'll give a little bit of a backstory on, getting the project off the ground, because that actually helps to set the stage for a couple of the issues that we ran into within the first 3 or 4 months of getting the grant off the ground that actually led to some of the work that I'll talk about today, which is essentially pre-project measurement work. And I've sort of nicknamed this work AIM 0 because it wasn't originally part of the aims of the grant, and there are actually a series of both conceptual and empirical papers that we've got cooking right now, one of which I'll get into greater depth on today, that sort of makes up work that NIAAA is essentially getting as a bonus for relative to what we're actually really supposed to be doing. So, something about this AIM 0 work. I'll give the origins of sort of how that germinated beginning this past summer. And the bulk of that work, at least the empirical stuff, actually centers around within study scale score estimation. Now again, with this being an integrated data analysis project, we had to deal with a lot of planning for between study scale score estimation, particularly as it relates to measures of PTSD, alcohol use, substance use, and the like. But there were some particular issues that came up that actually relate to estimating scale scores within the same study. Now, one of which I'll talk about today involves the idea of linking and calibrating multiple measures of PTSD within the same person. A couple of other examples are, using IRT to look at improving the accuracy of estimating and attending to clinical significance. A colleague at RTI, Lisette Saavedra, is working on that. And then differential symptom functioning across race ethnicity, which is a paper that Alicia is leading, where we actually find that accounting for differential item or differential symptom functioning actually leads to very different mean differences in IRT severity scores, even in the presence of the same patients actually having similar rates of PTSD diagnosis, in terms of differentiating those that actually met criteria for entry into Denise's CTN trial versus those that don't. So this is a couple of examples of things that came out of some of the work that we had planned this summer that actually wasn't written into the grant. So, what is Project Harmony? Well, as I mentioned, it's a multiple PIR one that Denise and I had to look at behavioral and pharmacological interventions targeted to patients with comorbid PTSD and AOD disorders. So out of the 50 studies that we had signed letters of intent to send us data for, we've got about a total of 4,500 folks. And so what we wanted to look at is the relative efficacy of different PTSD and AOD treatments, and then assess which treatments work for whom and how, in a way where you can actually do that in a comprehensive fashion where you've got a multitude of treatment types, and can actually engage in what we hope to be a fairly comprehensive look at optimal treatment matching. We're going to do this through what we call a novel, but I guess again, given some of this work has been done here with college alcohol use treatment samples, may not be as novel here as it might be some places, but I digress. Where we're looking at 3 data analytic approaches or frameworks to do this. So meta-analysis of individual patient outcomes, integrative data analysis, and we're actually incorporating some non-randomized trials within this, so there's some element of propensity score weighting that will be cooked into what we had actually planned to do. So here's the investigative team. Again, Denise and I are MPIs. It's a project that is a collaboration between investigators here at Rutgers, but also elsewhere within what I think is still would be considered part of the Long Island node of the NIDA CTN, RTI, and Medical University of South Carolina. So the RTI contingent composes of myself and Lisette Saavedra on the end. The Long Island node of the CTN contingent, Denise, Alicia, Teresa Lopez Castro, who's at City College, Sky, which is here, Sarah Cass, Amy Campbell also at, what's that, Belgium?
Columbia.
Is that Columbia? Okay. Sudi Back is essentially the psych PI at the Medical University of South Carolina. Therese Killeen is also part of the team, and Kathleen Brady is also a consultant on this. So, why did we start this endeavor in the first place? Well, the state of the literature at the time that we were looking to do this project centered around the notion that integrative treatments for PTSD and substance use disorders seem to be the optimal way to deal with that type of comorbidity. And the types of treatments that were being employed and being advocated for in the literature really boil down to, I guess, two types of treatments, at least on the PTSD end. Whether or not we looked at trauma processing interventions, prolonged exposure being one of those where there was more of an emphasis on actually dealing with the trauma or traumas themselves versus skill building interventions like seeking safety. They had never been pitted against each other within the context of randomized controlled trials, or certainly any single RCTs, much less anything larger. And that there's theory that suggests that trauma processing versus skill building interventions might actually benefit different types of patients. So for example, fear-based traumas might actually be better targeted with trauma processing interventions versus non-fear-based traumas might actually be targeted better with skill building interventions. So that's one of the things that we want to look at in terms of treatment matching. And there's several other things, whether it's primary substance use diagnosis, potential demographic differences, types of trauma, multiple traumas, and the like. Sort of figure into the calculus of what we want to look at within the context of the larger brain. Now, I did mention that they had never been pitted together within the context of clinical trials. Now, there have been limited cross-study comparisons between trauma processing and skill building interventions, but those were in conventional meta-analyses. But we argue that those meta-analyses, in fact, some of the folks that actually conducted the meta-analysis also cite these methodological challenges themselves. So, and there are many. Small within study ends, you know, again, even within the context of the studies that we want to look at, the average end is about 90, and many of the studies are lower than that, so that's probably more of the studies have a smaller end than 90 than those that have a larger end. A lack of direct statistical comparisons between trauma processing and skill building interventions. One of the things that I'm particularly interested in is the confounding of effect size estimates with the types of within study comparators. So it's the notion that trauma processing studies seem to have, on average, larger effect sizes than skill building interventions. But one of the things that, in sort of a limited examination that I kind of noticed, was that the trauma processing interventions also tended to have weaker comparators. So you'd see some effect sizes based on comparisons to wait lists or minimal attention interventions, while some of the skill building trials actually seemed more likely to have credible TAUs as comparators. So you'd see improvements across both conditions, but comparatively you wouldn't see anything in terms of differential effect sizes. And so that's something that I was particularly interested in looking at. The notion that making inferences about between study predictors doesn't guarantee that the same predictors operate in the same way at the individual level. And the problem is you'll never be able to get at that in a conventional meta-analysis. That's something that you can actually do within the context of doing this with raw data. And then there weren't any studies of mediators or moderators across treatment approaches or treatment modalities. So that was part of the justification that we put forth in the grant. Conversely, doing this in a meta-analysis of individual patient outcomes framework, it allows us to get at the individual level, as I mentioned, in ways that you never can with the standard meta-analysis. You've got larger cross-study sample sizes for subgroups or moderator analysis, whether you want to look at demographic differences, whether you want to look at other factors that you wouldn't ordinarily have power to look at in terms of moderation or mediation for that matter. You have much more control, and you have direct control over the analysis framework that you apply to the data, whereas when you're looking at a series of articles, the effect sizes that you have, you're really beholden to what analysis they conducted in the study. And mind you, you can actually put that as a factor within the meta-analysis. I get that. But, you know, things like, you know, accounting for